morning. All right, so let's get started. So today we're talking about age and fertility. So we want to get started with this question that we get asked very frequently. And it is, when is the right time to test my fertility? And, a lot of our experts will say there's no time too early to test. It's always good. Knowledge is power. But these are some questions we want you to ask yourself. A, have you ever had your fertility tested before? Are you 35 or older? And are you looking to have at least one child in the next few years? If you answered yes to two or more of these questions, it's a good time to get your fertility tested and come get a consult with one of our Kindbody experts. So just to frame the conversation, I just wanted everyone to sort of ask themselves those questions and sort of evaluate where you're at in your journey. All right, so I want to introduce our host today, Dr. Angie Beltsos, who's our Chief Executive Physician and a reproductive endocrinologist and infertility specialist with Kindbody. And we're so excited and so blessed to have her with us today. And she's going to be tackling this exciting topic of age and fertility. So I'm going to hand it over to Angie.
Hello, everybody. Thank you for taking time out of your busy days to spend it with us. And we're really excited to speak with you today. One of the things that just is so important is this mission to really revolutionize fertility care. And hopefully seeing me and you're seeing us, that you have this amazing experience. We've got a lot of innovation that we're using along with standard operating and evidence-based medicine, but we've got you, and one way or the other, we will help you get to your dream. So with that, let's talk about the topic of today, which is age and fertility. There are a lot of things that this might affect. We are looking at, what we do in Kindbody involves a lot of different things. Some people have been trying to get pregnant without success. Others have been trying and unfortunately miscarrying. Others haven't started trying yet, and we're really looking at the potential of preserving fertility. So let's talk through a little bit more about ways to help support your individual story, your individual journey, and things that can go along with it might include lifestyle changes as well. When we think about, this idea of fertility and aging. So let's go start with the agenda. The next slide. We're going to go over some of the facts. We're going to look at ovarian reserve testing and getting tested, age, and what age is important to be tested, and what some treatment considerations might be, and success rates. We'll also touch a little bit on male age. So obviously it takes two to tango, and what affects female and male aging. So next slide, why does it matter so much? What is so important about our age? For women, we are born with all of our age, with all of our eggs. And so our eggs are as old as we are or how old you are. So if you are 35 years old, your eggs are 35 years old. A man has sperm, but he is making sperm new. So the sperm we see today is only 3 months old. But when you look at both fertility and aging, they've been closely linked, particularly to the age of the female partner. And, this is, if you had to pick one thing, this can be a very important factor in predicting success. Next slide. So if we look at infertility, they define infertility for women less than 35 is no pregnancy after 1 year of trying. But at 35, we say that infertility or the evaluation of fertility should occur even as short of 6 months. And the reason, just on the aside of that, is that if you have someone whose age is affecting fertility, we certainly don't want them to lose the chance of getting tested sooner because their age is more fragile. So I hope that makes sense. But let's look at some stats too. 1 out of 6 adults experience infertility, and 1 out of 3 actually are related to the male factor. And if we think about this, the female factor is 1 out of 3, and combo is 1 out of 3. So to get to baby, I think you can look at all of these combined. When you look at a woman's age, that's a big deal, particularly in getting pregnant and having a healthy pregnancy. But we also know that for the male patient, age 50 seems to be the cutoff, where that might be 10 years sooner for a woman, where age is really starting to have an impact. So I think when you look at the next slide, please, is what are the 3 things we need? We need a healthy egg, a strong uterus with open fallopian tubes, swimming sperm. Next slide. When we test the amount of eggs that a woman is born with is around 2 to 3 million. And by the time we've reached our period, and next slide from that, we're down to about 300 to 400,000 eggs. And from there, get pregnant. We're on birth control pill. It is in some ways so unfair. And I think hopefully everyone can hear me, but it sounds like it might be a little choppy. So hold on. Audio is awful. Hold on. What I'm gonna do, let's see if I can fix that. One moment. I know it's hard to hear. Sydney, are you able to hear too?
Yes, I can hear it's coming back now. It was off for a couple seconds there, and it seems to be back now. I think you can try if it happens again, you can try turning off your video. Yeah.
Okay, I'm gonna shut the video off, and let's see if that's better. And I'm also gonna see if I can get a better reception. So just shout out if it's not clear, and I can repeat myself until we get that straightened out. But evaluating egg health, one of the important things is ovarian reserve testing. So when is a good time to do this in the menstrual cycle? Maybe some suggest that right when your period starts, in the first few days, is an ideal time because kind of everything's at rest. And so we do this FSH, which is follicle stimulating hormone, and it's reflecting the function of the ovary. And we like that number to be lower, less than 10. AMH, which is anti-Müllerian hormone, that's reflecting more of the quantity of the egg. And we like that number to be a little higher. So the number should be greater than 1. Some suggest somewhere between 1 and 5. Estrogen is also a great thing to know. And in the beginning of the cycle, estrogen tends to be lower. So less than 80, less than 100, because everything's at rest. But when we look at ultrasound, we're looking at antral follicle count. So the antral follicle count is measuring how many eggs you can see. Next slide. So when you think about financial reserve, we think about how much money's in the bank. When we think about the ovarian reserve, it's how many eggs are in the bank. So antral follicle count can be very important. And here in this picture is an ultrasound of the ovary. And can you see these little black circles? Inside each of those follicle cysts is a baby egg. So those are cysts on your ovary. And when people hear, oh my gosh, there's a cyst, they're worried. But actually, those are just where your eggs are contained. And each month you can see usually around a dozen follicles or a dozen eggs on each month. Your body picks one egg, one of those to grow, and those will be the egg of the month. The rest of the eggs just kind of disintegrate and bubble away. So every month, a set of eggs comes to the surface of the ovary, and you use one, throw the rest away. So actually, the efficiency of usage here is quite low. However, we have a lot of eggs from which to choose, and those are called antral follicles. The next slide talks about what's all the fuss about this age. It appears that as we hit our mid-30s is when the ability of those eggs to make a baby begins to decline more rapidly. And so this age seems to be very important to our fertility. 1 out of 10 women can start to have this decline happen even before age 35. And so it isn't just this sudden switch that you're totally fine before 35 and at 35 it goes off. But as we age, our age eggs with us. And doing your ovarian reserve testing, looking at your AMH, your FSH, your estrogen, so those are all blood tests, and doing a quick ultrasound and looking at your ovary, what it looks like, that can give us a lot of information about how well your ovary functions. The next slide is talking about the egg quality and quantity. Both of those are important. But so if you think about how many are left, but also that the eggs that we have remaining may also not be as strong. So their ability to actually fertilize, to grow as an embryo and implant is one piece. And then staying pregnant is the other piece, because there is increased risk of miscarriage as our eggs go through that normal weakening that occurs with age. And then the chance of passing on something like things that where the DNA of the egg and the sperm, when they come together, the risk of abnormalities like Down syndrome can also increase. So this is the important piece about how eggs and egg quality can be impacted by age. This next slide looks at age. So we break down women that are less than 35, 35 to 37, 38 to 40, 41 to 42, and greater than 42. What you see is that the weaker eggs increase by that gray bar as we hit our 40s. And therefore, because the egg is weaker, the chance of having a baby that and the live birth goes down. And they are reciprocally related. So this is a very powerful graph showing in embryos that they do have a higher chance of being abnormal as we get older. So how do you know if your embryo is healthy? First off, you can see the embryo growing and see how the egg fertilized, if the embryo is dividing in its cells and growing. Once it gets to about day 5 to 7, it will blossom like a flower. And at that stage, the grade of embryos is based on what they look like. If you look to the right, we see that this embryo is got a shell around it. It's translucent. And in the center is sort of a center of cells. Those cells are going to make the baby. And the next layer makes the placenta. So we give this a grade, which is a number, letter, like school. Exams are done and you get graded. This is a grading of the embryo once it's reached its blast stage. Once it's big enough at the blast stage, you can take a little skin biopsy. Imagine an orange, and you can just pinch some outer layers of that orange and test those cells to see if this embryo has the right amount of DNA from the egg and sperm. So the egg gives 23 pieces of DNA, the sperm gives 23 to make 46, and they're labeled in pairs the last pair determines sex. And people ask, well, how accurate is this test? It's amazing that this little embryo, which is like a piece of dust, the size is so tiny that you can take a pinch of that and test it. And we have about a 90% accuracy. There are times where the test is inaccurate. And again, that's a really important part of this screening. And we can see that there are times also where that DNA doesn't amplify and you don't get a result, which can occur. You can test embryos for other things, like if someone carries a disease in their family, like PGT can be done for diseases, and if someone is born with a broken chromosome. But the goal here with PGT and the best embryos is hopefully to optimize the chance of that embryo implanting and hopefully less chance of miscarriage. So, when you're looking at PGT, this is most commonly done with PGT-A. And A stands for aneuploidy, and that means you're counting chromosomes. So it has the right balance of chromosomes from mom and dad, or the egg and the sperm source. Who should do PGT? Well, everyone should know about it. That's the first part. But people that might be older, they might benefit, because we said that as we age, whether it's natural conception or people that are trying with their own eggs or even with a donor gamete to optimize outcomes. If someone's had multiple miscarriages, 2 or more, or they aren't getting pregnant with regular IVF, those are things that can be done. Family history of a genetic disease, or you or your partner may carry something, are all great considerations to think about PGT. And when we're testing PGT is pre-implantation, so it's before the embryo is implanted, genetic testing. If someone is trying on their own, remember first off that nature does PGT. So embryos that are unhealthy typically don't implant. And if they do implant, they typically miscarry. But once you are pregnant, you can check the baby with a blood test, ultrasound, and even non-invasive as well as invasive testing. I think the other thing is genetic testing of our patients can be done to see if they carry any diseases. And I know that there are some tests that can be done even if you're trying naturally. So what are the benefits is that you're going to know with about 90% certainty that these embryos that we're going to transfer and that have been produced are healthy if you're doing PGT. Some people want to know the sex of the embryo. Other people would like to be surprised. And it, again, may improve the odds that that embryo, because you've already found that it would for sure miscarry or it will never make a baby based on its genetic findings, it can optimize implantation with less chance of miscarriage. Once you are pregnant, again, there are other things that we do to make sure that the baby's healthy and help give you information on that. Next slide. So let's assume someone did do IVF. When your eggs are growing, we count those follicles, and those are the ultrasound cysts that I showed you earlier. Usually you'll get an egg from most of your follicles. So let's pretend that I was looking at 12 follicles. Let's say that we could retrieve or take out 10. Now we're going to put them with sperm, and we expect 70% of eggs to fertilize. So now that would take us down to 7 little embryos that are growing in the dish. Usually about half of embryos can grow to the blastocyst stage, and that is age dependent also. So let's say now we're down to about 2 to 4, and then some of those, depending on how old we are, the PGT testing hopefully will show us a normal. And then of the normal embryos we transfer, we can get a baby. What's important in this is to manage our expectations, right? It's that upside down triangle that you start off with a lot of eggs, but in the end, you're getting down from quantity to quality, and hopefully really good embryos to transfer. And this happens also naturally. Not all eggs that we ovulate fertilize, and not all of them will grow, and certainly not all will implant. So these are helpful because we can see in the dish what the human embryo typically does. Now, next slide we'll go over a little bit of like, well, what should I do and how likely are these treatment options to work? And if we look on the left, we've got an average 35-year-old who takes some medicine. So medicine, if you're trying to get pregnant and it's not working, we could give you a pill or a shot. Typically, when you're trying on your own, which timed intercourse is TIC, so you guys are trying at home on your own, or intrauterine insemination with a pill has around about a 10 to 15% success rate per month. When we go to IVF, and again for a 35-year-old, success rates will run around 40 to 50% and are improved by 10 to 15% by adding the PGTA, because now you're taking those embryos and putting them through another screening process to see if they're even stronger than what they look like. So it gives you an extra piece of data. Now, how likely is IVF to work? This was based on over 300,000 women of the SART registry. And we said, what if you're 35 and what if someone else is 41? So here, that 5-year, 6-year difference, they're trying in that first year or first time of trying an embryo transfer, no PGT, the chance of getting pregnant is around 40%. Even in that short 5 years, look at that. It drops in half to around 20%. By the time someone's tried a second embryo transfer, and the first one didn't work, 60% are pregnant, whereas the age in a 41 is half of that, 31. And by the time someone's tried 3 IVF cycles, almost 75% are pregnant, whereas again, it's cut in half by age. So this illustrates that still, sometimes a little bit like baseball, you got to swing the bat a few times to get that home run, but also the effect of age on our ability to conceive. But next slide, at the end of the day, I think what's I've learned in taking care of patients all these years of being a patient, that there's not always one way of doing this, one magic formula. And just like how we look, how we think, our fertility needs to be thought of in our own unique story and what we bring to the table. So what we want to do is use evidence-based medicine. You start with standards and really make good decisions for yourself. And there are a lot of ways to get to, to get to baby. And I think what we have to do is think through how that can look. Next slide. Now, what you can do if you're at your initial consultation, we go over your story, discuss what you bring to the table, some of your medical history, the family planning goals you have. If you say, I want 1 child versus 3, how do we strategically, get you pregnant to have your first baby, but also thinking long term, what does that strategy need to be to have the family you dreamed of? And then again, personalizing everything around you based on that consultation. So I think that's, a very important step in the right direction. And then thinking about the options. We have, some people, it's discovering what was going on, whether it might be a fibroid or a polyp, and figuring that out with the fertility treatment that might be necessary if you don't ovulate, IUI or IVF. And then sometimes things need extra support, like an egg donor or a sperm donor or someone to help carry the baby. But there are a lot of options, a lot of different things that we can do to help you. So to get started, if you have already met with us, that's amazing. If you are ready to schedule your first visit, I look forward to helping you. My team does. And we are going to do whatever we can to help you get to the family you dreamed about. And some patients have coverage from their employer or their, or they're covering insurance, and that's great. But if not, we can help you also figure out how much is this would cost to do the testing, what treatment choices you have, and how much they cost. So thank you for that. We're on our Q&A slide. So let's talk a little bit about your questions. Um, so glad that the first patient is here too. And we have a 32-year-old, successful career, woo woo, homemaker, homeowner, great life, and thought I found Mr. Right, but he was Mr. Oh so wrong. Well, I'm sorry that all that you went through all that, and you said that it's been, a long time also with your time that goes about away with all this. So you're interested in egg freezing and who might be and who that might be the right option for. Well, I like everyone to think about egg freezing if they're not ready to get pregnant now, especially early from the late 20s, early 30s, and beyond. So basically, it is 2 weeks where you take medicines, and when the egg is ready, we do a trigger shot and collect the eggs. And I think what your question is very powerful, and that is check your fertility and also consider this. And um, you're not sure what life has in store, but it's nice to have these. A lot of people that freeze eggs end up finding Mr. Right and getting pregnant naturally, but you have these in case you need them, or a lot of people want them for baby number two. Um,
Angie, would it be helpful for me to feed you the questions so that you don't have to read
that'd
them?
be great. That'd be great.
Awesome. Okay, let's keep going. So I'm going to pull out, and just so you know, we try to keep the questions relevant to the entire group. So if there are some very specific personal questions, we'll probably ask you to send us a message about those. We want everything to be relevant to a larger group. So I'm going to pull out the ones that I
Great.
think make the most sense. All right. Okay, this is a great question. So this person had her fertility tested last year and her follicle count and AMH were high. So when would you recommend going to test again? Every year, every other year, every 6 months? What would you recommend?
So one is if your AMH and antral follicle count are high, that means you have a lot of eggs, which is a great thing. And sometimes that could be a sign of another condition called polycystic ovarian syndrome. So I would explore PCOS. Number two is that you might act on it right then, or you might say, look, everything looks really good. I'm just going to repeat this test in a year. So I would say, getting your fertility examined, especially if it might change the actions you take.
Great, thank you. This is an interesting question. I think, and I'm going to expand on it because I know I get this question all the time running our social accounts. There are a lot of myths and misconceptions around fertility. Some of them that I hear all the time is, oh, well, my mom had no problem getting pregnant, so I'm not going to have a problem getting pregnant. Or, I've been pregnant in the past, so I won't have a problem getting pregnant again. All these myths and misconceptions around, I don't have to worry because X. What would you say to those, specifically fertility being genetic and having had a previous pregnancy? Does that indicate that you won't have a problem?
Yeah, the best predictor of when our eggs stop working and we go through menopause is the age our mom did. So that is an important thing to keep in mind. So, for example, if mom went through menopause at 37, 38, you're the person that absolutely should go in and get tested and consider fertility preservation or trying to get pregnant sooner. Certain medical conditions can also put us at risk, as well as the story that happened with sometimes our family, risk of miscarriage, fibroids, and things like that. So I think those are genetically important, particularly to what we're talking about today. In regards to, I think men, they tend to have fertility for a much longer time. And if there were other medical things that might happen, women related in your family, those are things to have examined ahead of time as well and be proactive.
Okay, thank you. Interesting question. So, how do kind body providers and clinic staff set expectations for patients of advanced maternal age? And what services what supplemental holistic services might we offer? Is there mental health? Is there nutrition, counseling, et cetera?
Great. Okay. So when we talk to our patients at Kindbody, we use some of these slides and these slide decks to help us frame what we're talking about, not only with words, but with these graphs that can help identify our own story based on our age. And I think that is really powerful because it lets you make decisions based on data. The second thing is nutrition can be very impactful. So egg supplements that include CoQ10, antioxidants, prenatal vitamins. Those are examples of things that you can do to help improve your nutrition. Avoiding the inflammatory diet is something that's being examined, such as fake sugars. Some people say dairy. Things that can be even related to gut health can help improve the probiotic use, can help improve the milieu of the reproductive organs as well. We do have a Kindbody 360 that has nutritional support. We also have mental health support in there, and psych education as well to to really support the emotional side of this. And I think acupuncture and holistic medicine can be very powerful too. It's very relaxing in the sense of shutting off the screen and taking a moment to be mindful. And that can be very powerful to us to quiet the noise in the day. And also, it is to help improve blood flow. So I've personally seen a lot of my patients use the things that I just mentioned with great success, and also supporting some of the advanced medical care that we're providing at Kindbody.
Absolutely. Let's talk. Okay. And I'm going to ask this question, but I would encourage this person to join us on Friday while we're doing a deep dive on male factor. But I'm going to ask Dr. Beltsos this question in case you can't make it on Friday. What testing do we do for male? For those born male, what would we do for fertility testing?
Yeah, thank you. That's such an important thing because a lot of times people forget that these three critical components, the egg, the uterus, and the sperm. So how do you test sperm and what's relevant? The first is a basic semen analysis where you check how many sperm you see, how fast they swim, and their shape. But that's just the start. When that all comes back normal, that still could require further testing. Unexplained infertility and recurrent pregnancy loss are two examples where the male factor is critical to further examine, like DNA fragmentation. So the first one is telling you a little bit about qualitative measures and if it moves and its shape. DNA fragmentation is telling you how strong that nucleus is that contains the DNA the sperm is giving. Sperm DNA is loosely packaged and can break. So DNA fragmentation can be a very insightful thing for us to understand a little bit more than just looking at one sample. Number three we have Kind9, and these lab tests are 9 hormone levels that can be very important to the function of the testes and the sperm. And finally, testicular ultrasound can be done to examine for any abnormalities there. Remember that male factor is associated with cancer, and it does require further examination to just be sure that we're doing everything we can to get to healthy baby, and of course, further examine any abnormalities in the male partner.
Absolutely. Okay, this came up a couple of times. Can you talk about the difference between our sort of preconception genetic testing on the parents, or the two people, or the donor and the parent? Talk about the difference between doing that type of genetic testing and PGT.
Yeah, that is a common question because we said genetic testing.
Mm-hmm.
But genetic testing, there are a lot of different kinds today of genetic testing. It's like you said, I had a blood test where you're like, well, what kind? PGT is embryo testing. So you have to do IVF in order to do that. And you're testing the embryo, which is just that particular egg with that particular sperm, and seeing if that embryo contains anything. And sometimes it's a fluke that there was a mistake made and that embryo is affected with something problematic. The genetic test of us as a mom or dad, that is checking to see if I inherit anything from my parents. So those are carrier screening if you carry any conditions from your parents. That is a little mistake on the DNA that results in a disease. A lot of times what we're looking for are what are called recessive, where both the egg and the sperm source have to be carry it for it to be affected, or it could be something that happens as a fluke in that embryo. So that's genetic testing of the person, and you're checking to see if you carry any diseases that could affect the baby. The third kind are genetic testing of you might be a chromosome translocation or a deletion, and those can be a broken piece of your DNA, and the way to do that is karyotype. So karyotyping can be done, and diseases can be also screened for even cancer risk and things like that. All those fall under the umbrella of genetic testing. And your question's really good because a lot of people get confused on, well, my genetic testing of me was fine, so I don't need to do PGT because I don't need that.
Mm-hmm.
And it's not exactly true.
Yeah, it definitely comes up a ton. Let's talk about what combination of factors would you recommend in what combination of factors would you recommend the use of donor egg?
So if the egg that you have isn't producing healthy embryos or a child or repeated miscarriage, then using someone else's egg might be a consideration. The majority of people that use donor egg is related to age and that the ovaries are no longer able to produce a good egg. So in this case, we use an egg from someone else, and typically someone that's younger, often in their 20s, where the egg health is optimized in that age.
Okay, thank you. Okay, this is an interesting question, and we actually had a session yesterday with Dr. Jelani about chronic conditions and how they impact fertility. And let's talk a little bit about that because this group may not have been there. So this question is about, can you do an egg retrieval if the person has fibroids? And then similarly, we talk about endometriosis all the time and PCOS and all these cases that impact fertility, but let's specifically anatomically, fibroids, endometriosis, how does that impact the ability to do an egg retrieval?
Usually, even if you have some of these conditions, we can still do your egg retrieval. Egg retrievals are done with a vaginal ultrasound, as most of you know. And when you place the ultrasound probe in the vagina, you can oftentimes get to the ovary directly because the vaginal skin inside just rests against where the ovary usually lies. If there's a fibroid there, oftentimes I can push the fibroid away a little bit so that I can access the ovary. Endometriosis can cause scar tissue. And again, that typically does not preclude me from being able to get to the ovary and get to eggs. Occasionally, the ovary is far away from where I'm working, and because the fibroid is bigger or in the way, there are times that I can't get to it vaginally. I might try to put the needle in through the abdominal wall. So we just switch locations of where I'm poking the ovary. Third is that sometimes I can't get to it safely, and we will have someone remove their fibroid so that it's out of the way, and then we can get back to accessing the ovary. But sometimes you're even in a situation where I can only get to one, and you may have heard that before too, that only one ovary was accessible safely.
Yep. Okay, there's so many good questions, and I hope we can get to a couple more. Let's talk about, this question comes up a lot all the time as well. So is there any way to improve the quality of your eggs? Diet, exercise, vitamins. Is there anything you can actually do to improve the quality of your eggs?
Yeah, that some of this is biological change that um, can't be reversed. Things to not do include smoking. Smoking and vaping will permanently damage the ovarian function. So we know that's one thing that can cause premature menopause. um, Nutrition. See, these eggs you were born with, they're deep in the ovary asleep. And so there's been a lot of work trying to understand ovarian health. How can I make the egg better or at least improve the situation a little bit? So micronutrients have been studied. Again, these antioxidants is one arena. We talked about the anti-inflammatory diet and how these pseudoestrogens can affect both men and women. Don't microwave your dishes, your leftover spaghetti and in plastic. Use glass. Try to avoid the plastics because those pseudoestrogens are affecting. We see even the male fish in the water look like female fish. This pseudoestrogen can affect even how the ovary functions, and some of the toxins. Uh, there are medicines that can affect health, like methotrexate can hurt the ovary a little bit, but some of that's transient. And so, for those of you that are faced with a decision like, how do I manage some of the medicine I'm supposed to take to be healthy against ovarian function? And happy to talk offline, one on one with you if that's a question. But, other work in the world and, in this field of fertility. I'll throw out some way, off the beaten track. Ovarian rejuvenation is being examined. There's a study being done, and we're part of that study where you inject the ovary with PRP to improve ovarian function. Haven't seen a lot of success with it. Some studies have shown success, and I think it also depends on how bad the situation is for that woman. But that's one thing people are looking at. Nuclear transfer, cytoplasmic transfer, that's not being done in the United States, where you take someone's nucleus of their egg and put it in a donor egg, or take the cytoplasm of the donor egg and inject it into the woman's eggs. And again, that's data that's trying to like Botox or rejuvenate the oocyte itself. Quite controversial. But again, what else in the spectrum of things, people ask about that too.
Yep, absolutely. And then let's talk a little bit. I'm going to take two more questions. And then again, if your question didn't get answered, you can always send us a DM and I will get your question answered by Dr. Beltsos and respond to you quickly. So one question that we get all the time in preparing for a cycle. So, someone's, trying to get pregnant, either they're preparing for a cycle or they're trying to get pregnant at home. What is recommended in terms of lifestyle modifications? Would you say don't drink any alcohol? Would you say stop exercising? Would you say do exercise? What would you recommend when somebody is actively trying to optimize their fertility?
So a glass of wine is not um, problematic for the woman or the man. Once you have tried and ovulated or did your transfer, did your IUI, at that point, you should consider yourself pregnant and eliminate alcohol. 1 cup of coffee a day is good, if that's, or tea, if that's of interest to you. But once you are pregnant or you think you might be pregnant at that age or that time, try to limit caffeine use, and not no more than 1 cup um, per day once pregnant. No smoking. People are using more marijuana gummies and that sort of thing. So we know that we've seen slower swimming sperm with marijuana use. Well, that's maybe what you might expect. Some of it's been very problematic for certain guys. You might have a friend who smokes like marijuana a lot and has 10 kids, and yet in another guy, it'll drop the sperm count dramatically and will be the sole source. So being thoughtful about that. Um, as far as exercise goes, and you're trying naturally or you're doing fertility care, exercising is fine. We do recommend being thoughtful about how aggressive to exercise. If you are doing fertility care, talk to your doctor and nurse about how your ovaries look and how much you can do. Kickboxing, spin classes, yoga, especially core. the ovary, if it's getting bigger, can twist or tear. So you want to be a little thoughtful around that. And then once you're pregnant, and you will be, if that's what you want, we're going to figure it out. Then excess heat can be an issue. So hot tubs, jacuzzi, steam rooms, you want to limit that so you don't get overheated, which can be dangerous for mom and baby.
Yep, absolutely. Okay, I'm going to ask one final question, which is, I think, an amazing one. We don't get this too often, but I love it. What would you recommend to somebody who's vetting fertility clinics? What would you want them to look for? What would you want them to ask on a fertility clinic that they're vetting?
Yeah, that I think is a powerful question. And it's one where you feel confident in the team that's taking care of you, and you feel that you have that trust in the clinic and the physician that is in charge of your care. Things to look at in regards to success rates are always important, and understanding what the clinic is allowing to come across their treatment doors. So, for example, for me, when I looked for a place because I needed help, and also when I was looking at building my own practice, I felt as a woman that we often discriminate against those women who are in a difficult situation. And I have a lot of respect for my colleagues in Chicago, and we have amazing clinics here. And frankly, in our country, we're very blessed. But some of them will say, if this case is difficult and your FSH is over 15, or you're a certain age, or your situation, you've done IVF and haven't gotten successful, then they limit what you're allowed to do, your ability to try with your eggs, your ability to try with your uterus. With a very transparent and real conversation and dialogue, I think you should be able to try. And even if my statistics would be affected by those results, what's more important is that you and I come up with a treatment plan that's real and that has a chance, and we can always explore donor eggs and surrogacy in the future. So when you're looking for your doctor, make sure that that you feel comfortable, and don't hesitate to have these conversations with your doctor and your team. And if there are concerns, and certainly we strive for perfection, but there's no utopia. Talk about things that you might not say, but take that chance and say, you know what, I really need this from you. And this is some of the things that were bumpy, or these were the things that were great. Because I think all of us only want to work with you and to be successful together. And so don't hesitate to have a conversation with those that you do trust to be your care providers.
Absolutely. And just a reminder, and thank you all for joining us. Just a reminder, we do have 3 more sessions coming up. Tomorrow, we'll be doing
Yeah.
recurrent pregnancy loss with Dr. Bendixson. Thursday, we're going to be talking about access and equity in fertility care with Dr. Sasan. And then on Friday, we're going to be talking about male factor with Dr. Pollard. So if you are interested in any of those other topics, you can go to kindbody.com/NIAW. And Dr. Beltsos, thank you so much for hosting today. It was incredible. So
It's my pleasure.
and
I know there were a lot of questions. Happy
yeah.
to work with our team here and Sydney to help get you answers. And I wish you guys all the best. We're here for you. We'll figure it out.
Yes, we will. And thank
Don't
you
give up.
again. And yes, you will receive the recording in an email tomorrow. And please, if you didn't get your question answered, send us a direct message on Instagram, and we will send that over to Dr. Beltsos.
Great.
Thank you so
All right.
much.
Talk soon. Have a great week. Thanks, Sydney.
Bye, all.